All right, everyone, it's the top of the hour. We'll get started.
Thank you for inviting us to speak today. Our topic is on the renal toxicity associated with immune checkpoint inhibitor therapy. Immune checkpoint inhibitors are a novel type of immunotherapy that have changed the landscape of management in oncology, and it is a substantial advance. This is characterized by the use of monoclonal antibodies that are designed to target the inhibitory receptors that are expressed on immune cells and tumor cells. The receptors that are targeted include cytotoxic T lymphocyte-associated antigen 4, programmed death 1 protein, and programmed death ligand 1. Now, the immune negative regulators of the immune system have been designed as part of the immune homeostasis with the intent of preventing self-reactive T cell antigens and autoantibodies from destroying the host tissue. And it is using these natural homeostasis mechanisms that the targeted antibodies have functioned to allow immune reaction to damage and destroy tumor cells. Now, the CTLA-4 is normally present on T cells, and it tries to compete with CD28 to prevent and downregulate T cell activation. T cell activation is normally through the T cell receptor when it identifies peptides that are presented by the major histocompatibility complex, and there has to be a co-stimulation with CD28 and B7. So CTLA-4 tries to compete with CD28, and when it does so, it inhibits the activation of T cells. So when you use a monoclonal antibody that is targeted against the CTLA-4, you have a continuous state of T cell activation or overstimulation. And as a result, you have a hyperimmune system, which is utilized to destroy tumor cells. Similarly, in the more peripheral tissue or organ system, there are the PD-1 and PD-L1 negative regulators of the immune system. For example, here you have an activated T cell immune response where the co-stimulation is taking place. But when there's an excessive chronic persistent antigen stimulation or chronic infection, the use of PD-L1 as expressed by antigen presenting cells and PD-1 by the T cells downregulates or decreases the proliferation of T cells, diminishes cytokine production, and diminishes cytotoxicity. So there are antibodies designed to prevent this downregulation, and that causes an effector T cell immune response in the local organ region. So it is this theory that has been utilized by the novel therapies that are being used now to prevent activation of to allow overactivation of T cells and destroy tumor cells. And here you see that the activated T cell is working against the tumor cell, and the antibodies are preventing the normal negative regulators from controlling the environment. So you have an overactive immune system. So what is the mechanism? That by targeting these lymphocyte receptors or their ligands to unleash the anti-tumor response, you have immune reaction destroying tumor cells. CTLA-4 and PD-1, PD-L1 receptor blockade regulates these immune responses at different levels. The CTLA-4 really regulates the activation of antigen-specific T cells in the lymph nodes, and this is evident with mutated mice studies where mice that have knockout of the CTLA-4 have a lymphoproliferative process whereas mice that have a knockout of PD1, which is more